As we get started now with our keynote presentation today is titled Access to Maternal and Infant Health Care is Not Enough. Doing More and Doing Better is presented by our distinguished keynote speaker, Leslie DeRosette. Leslie has over 22 years in various public health roles and currently serves as a research investigator in the Department of Maternal and Child Health at the University of North Carolina, Chapel Hill. Leslie is an adjunct professor at the Gilling School of Public Health at University of North Carolina, Chapel Hill. She supports 3 national programs: the National Maternal and Child Health Workforce Development Center, the Maternal Health Learning and Innovation Center, and the Strengthening the Evidence for Maternal and Child Health program with the department, as well as a national preconception health program in the School of Social Work. Leslie provides technical assistance, consultation, coaching, capacity building, and training to states and public health leaders, which includes Arizona. At the end of the presentation, we will have time for questions. So please keep that in mind as I welcome Leslie to the platform. Leslie?
So let's get started. I'm going to spend just a little bit of time talking with you, and just want to say thank you again for inviting me here. So I have no disclosures to address. I'm here as myself, and like everyone has said, I do work with the Maternal Health Innovation Grant in Arizona, and glad to be able to work with them and get to know the Arizona projects. Our learning objectives for today are here on the screen. There are 4 major learning objectives that we will be hoping to achieve by the end of this time together. I hope that by the time that we finish together today, you will have a greater understanding of the root causes of maternal mortality and morbidity and infant mortality and morbidity that contribute to the overall health of the populations that we work with. I hope that you will have an ability to understand how these inequities and disparities work so that we can work together so that we can look at developing a robust workforce and an evidence-based and practice-based innovations in Arizona. So I want to start with just a little bit about me. One of the things I love about working with Arizona is the time that we always take to get to know each other. I originally come from Maryland and studied my undergraduate degree in Ohio. I landed my first 2 jobs in Georgia and South Carolina before I switched my career. I started out in advertising and telecommunications. Eventually making my way to a public health degree, I decided to join the Peace Corps with my husband in 1998. We spent 2 years working with the Hispanic population in Nicaragua. My work was specifically with women and children around public health. I then came back to North Carolina for the very first time and was the health director of a nonprofit called Y Centro Hispano, where I worked with Hispanic members of the community in the early 2000s to address chronic disease and HIV. Finally, I ended up at the March of Dimes working with their preconception health program and focusing on reducing neural tube defects among the Latino population in North Carolina. It was an amazing 7 years of work. Finally, I decided I needed some more education, so I went back to school to UNC to complete a second master's in public health. I then was fortunate enough to schedule time to work with the North Carolina Department of Health and Human Services, the Public Health Division, with an amazing group of people around maternal and child health issues. I was there for over 4 years before I returned to North Carolina in 2018. I'm extremely happy to say that I currently work with the School of Public Health and 3 national maternal and child health projects that are seeking to address and advance the inequities and disparities we see in maternal and child health. Most of us have a why as to why we do this work. I have 2 children that look very different as you look at them here over the lives that I've had them. They are 21 and 19. Before I got pregnant, I didn't think about what I did not know or what were the factors of my health prior to pregnancy that could have contributed to their health. Even being in public health for 6 years, but mostly in chronic disease and STIs, I didn't know how my Jewish heritage, my chronic disease, my family's chronic diseases would potentially affect the health of my children. It wasn't until after I had my children that I became versed in understanding how my history, the history of my family, or what we commonly refer to as preconception health, contributes to their lifelong health. So my why is my experience in the Peace Corps, my many years in North Carolina, and my family that help motivate me every day to address the historical and current inequities in maternal and child health. So let's take just a few minutes to go over some very high level data. After this presentation, you are going to have a break, and then you'll hear from colleagues on the Arizona and the US data. Therefore, I don't want to bore you or spend too much time on it. I do also want to state that I will be using terminology such as American Indian and Alaskan Native, Black, Hispanic, and White, Native Hawaiian, and other Pacific Islanders to refer to the races and populations that I will be speaking about. I will also use words such as birthing person, birthing individual, and women of reproductive age to refer to our population of maternal and child health. The maternal mortality is moving in the wrong direction. We've already heard that twice today. In 2021, over 1,200 women died of maternal causes in the United States, an increase from both 2020 and 2019. The maternal mortality rate in 2021 was 32.9 deaths per 1,000 live births, compared with a rate of 23.8 in 2020 and 20.1 in 2019. We know that disparities exist in the data. The increase is from 2000 to 2021 were for all races and Hispanic origin groups. Everything was a significant increase, but we know that the increases were worse for our non-Hispanic Black population. In 2021, non-Hispanic Black birthing persons were 2 to 3 times more likely to die compared to other races and ethnicities. Black women had a rate that was 2.6 times the rate for non-Hispanic white women. The maternal mortality ratio over the last 2 decades has seen an increase from 12.2 per 100,000 deaths, 12.2 maternal deaths per 100,000 live births to 32.2 across the United States. These data vary racially, ethnically, as well as geographically. Overall, we also see variations in the rates by the geographic location of the United States. For every maternal death, there are about 60 birthing persons or pregnant persons, or close to 500,000 birthing people who have a near miss, a life-threatening complication during pregnancy or within the first year of pregnancy. The severe maternal mortality in the United States has been increasing every year. Similar to our other data, our rates vary by race, ethnicity, and geography. When we look at going to talk about infant mortality, you can see that the darker color is less than 4.0 infant deaths per 1,000 live births in 2000. Our lowest rates happen to be in Massachusetts and California. In the United States, the overall rate is 5.4 per 100,000 live births. In Arizona, the rate is 5.2. As with similar data, these data vary by race, ethnicity, and geographic location in the US as well as in your state. You can look here to see the race and ethnicity disparities in infant mortality in 2019 and 2020. You can see that the Black, American Indian, or Alaskan Native, Native Hawaiian, or other Pacific Islanders have the highest rates of infant mortality. When we look at some of the mortality and morbidity for 2020 and 2021 in Arizona and the United States, what we can see here is that the rate of 5.2 and 5.4 for the United States is the number of infants that die. In Arizona, this is 399 babies that have died in 2020. 1 in 10 babies in Arizona were born preterm in 2021. African American or Black people had the highest rates, followed by Native American and Alaskan Natives, followed by Native Hawaiian and other Pacific Islanders, and Hispanics. This data is compared to non-Hispanic white. The C-section rate in Arizona has remained steady since 2011. In the US, our rate has fluctuated from 27.6 in 2011 to 32.1 in 2021. 1 in 13 babies in Arizona were born low birth weight. Black infants are twice as likely as white infants to be born low birth weight. This rate has continued to increase since 2011. The data we just went over was a lot. Take a breath and breathe. Remind us what Felicia has told us earlier. The data we went over was a lot. It's nothing that you haven't seen before. We are aware of the maternal and infant crisis in the US and in Arizona, but we have to step back and ask ourselves why. What is contributing to the inequities and the disparities in maternal morbidity and mortality, infant mortality and morbidity? What is the role of the MCH workforce in helping to get to the root cause? We know the social determinants of health are a major contributor to the overall health of where we live, work, play, pray, and these are the assets that make up our communities. Without access to grocery stores, healthcare, transportation, parks, sustainable and reliable transportation, and employment, our health suffers. The health of the American Indian, Alaskan Native, and Black birthing population is negatively impacted by the discrimination they experience, which can increase stress and cortisol levels and had adverse effects on maternal and infant health. Many of you have heard of the weathering hypothesis. This has demonstrated chronic stress is linked to socioeconomic disadvantage and discrimination over the life course, causes pregnancy to be riskier for those experiencing these lifelong stressors compared to those who do not. Black and American Indian Alaskan Native women are more likely than white women to experience discrimination, delays in care, and to see a different provider each time they attempt to access prenatal care. Research has found that over 25% of American Indian Alaskan Native women report experiencing discrimination when going to the doctor or a clinic. For the Black population, this has been found to be even higher. The lack of equity in healthcare is directly related to the systems that we have created. It is directly related to racism. In the US, our systems of care lack equity and perpetuate discrimination and racism at all levels, including the individual, structural, and institutional. As we move forward to address disparities in access and quality of care, we need to move from equal care to equitable care. The services we provide must address the inequities and disparities of the populations. We should continue to identify the social, economic, and demographic and geographic barriers that limit the creation of equitable opportunities for our birthing populations across the US and in Arizona. A national organization named Roche developed this theoretical framework in 2016 to address the Black maternal health crisis. This framework identifies the social and structural determinants that need to be addressed to meet the Black maternal and infant health crisis. Things like education, safety, food, housing, stability, access to care, and income. What the framework also does is outline the root causes of trauma and historical injustices that have contributed to the Black maternal health crisis. Root causes such as slavery, Jim Crow, the 13th Amendment, and the GI Bill are just some of them. This framework shows us visually that in order to reduce the inequities in maternal mortality and severe maternal morbidity, as well as infant mortality and morbidity, we need to move beyond the clinical and behavioral risk factors and address the social and structural determinants of health. Again, we can think about how we see life course theory and a person's preconception health and its impact on maternal and infant outcomes. This framework also shows us where we can intervene at the structural and systemic and structural levels. This framework can also be adopted to think about the American Indian and Native American maternal health crises with a few changes. Many of the structural and social determinants are the same for the American Indian, Alaska Native populations in Arizona and the US. Living in rural and frontier communities, living on tribal reservations, lack of access to prenatal care, high quality care, maternity deserts, income, safety, food, stability, and education, and incarceration. However, the dashes that go along to identify the historical trauma and racism that Black people in the US experience differ for American Indian and Alaska Natives. Here, we would need to think about adding the 350 boarding school children that were sent to boarding schools. We would need to think about the historical trauma, the cumulative historical multi-generational trauma that affects us emotionally and physically. We would think about the 1830 Indian Removal Act, forcing people off their land east of the Mississippi, the removal of food and resources on the land that you live. And finally, we would be thinking about the colonization of the United States. I won't pretend to be an expert in this area, but when we begin to think about how to face the high mortality and morbidity among women and infants, we need to look outside the medical communities and look at these root causes and the historical trauma that our populations have faced. So we're going to switch gears a little bit and start to talk about what the root causes of we're going to talk a little bit about the maternal and child health workforce and how they can begin and continue to address the maternal mortality and severe maternal morbidity crisis in Arizona. There are so many opportunities that we've already seen this morning from your bureau that Arizona is already infusing information in, from their doula certification to Medicaid expansion, to the takeoff tomorrow of the Fetal Infant Mortality Action Plan. There is so much good work already happening in Arizona. And my goal is to share with you a few things that are happening across the US as well as in a few certain states. How many of you have heard of the Public Health Wins Survey? Can you put a thumbs up or an emoji thumb in the chat or just in front of your screen? How many of you have heard of the Public Health Workforce Interest and Needs Survey, PH Wins? Okay, I'm getting a few that not very many people have heard of it. That is okay. The survey is originally developed in 2014 and 2017. It comes from the Beaumont Foundation and ASTO. Our most recent data came in 21 to 2022, and here you can see some of the survey components. It is the only national survey in the US on the public health workforce. And the reason that I'm sharing this is because many of you do come from a public health workforce. Many of you come from a community-based organization. And I think it's important for us to understand where we are with our workforce and what diversifying a workforce really can look like and why it's important. So I'm not going to go through the whole survey. I'm going to highlight a couple of key points. This is something you probably know. Most of our public health workers are identify as white, identify as women, and over the age of 40. Although there's some increase in diversity, our executives are over 66% more likely to be white than another race or ethnicity. And then these are some reasons that people may be leaving their jobs in the next year. So almost 1/3 of our public health workforce nationally intends to leave their job in the next year. And these are just some of the reasons. 36% of employees said the pandemic is a reason they are considering leaving. This is not new to you. You've heard this. You probably have experienced it in your own organizations. There are high levels of stress and burnout amongst our organization, and more than half of our public health workforce is reporting symptoms of PTSD or post-traumatic stress disorder. 1 in 5 say their mental health is fair or poor. So you can look at the data here and you can see that our population of public health workforce may not feel completely supportive in their roles. There is potential for high turnover, and it's a little bit higher than it was in the previous surveys. Looking at this, you can see that Region 9 is where Arizona is located. State data is unavailable from what I could find, so I wanted to show you what Region 9 looks like. You'll see that most of the data looks very similar to what's happening in the US and in the public health workforce. The thing that stands out to me is the years in public health. 36% of people in Region 9 have been in public health for 5 years or less, while 30% have been in the field for 16 years or more. This indicates to me that we have a potential for a high turnover and loss of historical knowledge and skills from our populations that have been working in public health for so many years. We have a gap in our population between 6 to 15 years where it feels like people aren't staying as long. So they're coming in and they're staying for 5 years, and they're either going to stay the whole time or they're going to get out right at 5 years. So things that we probably should be concerned about. The other interesting facts here are the regions that people would be leaving. So 28% of Region 9 intends to leave within the next year. Within the retirement, we have about 20%, but we have 68% that are staying. So we need to dig in and really think about why are people staying, what's making people stay, or we can look at it from another way and think about what's making people leave. I kind of look at it from why are we having people stay? What's motivating them to stay? And here's what we're finding was that people feel the work they do is important. They feel job satisfaction, they feel organizational satisfaction, and they feel involved in their work. These are all opportunities for us to build on to increase our public health workforce and to increase their sustainability within our organizations.
Leslie, excuse me.
Yes.
It's Patricia. We have 10:06, just trying to honor your time.
Okay, thank you so much. So what I'm going to do is just go through a couple of quick ideas about the blueprint. How many of you have heard of the White House blueprint? Go ahead and put it in chat and let me know with a thumbs up or a thumbs down. The White House blueprint is was developed and released in June 2022, and it highlights the ways that local, state, and national MCF experts can address the maternal health crisis. So we have a couple of different goals that I wanted to highlight, and these links will be available to you after. Goal 4 is to expand and diversify the public health workforce. You'll see that there are many different action steps here focusing on doulas, licensed midwives, and community health workers. So one of the things that we want to think about is how your doula force in Arizona can be effective in addressing the maternal health crisis. This is data that you probably know that when we have doulas, we have a higher rate of birth outcomes, and that they have higher rate decreased C-sections, higher APGAR, and more likely to be breastfed. We have tons of data in this presentation that you can read after about the successes of doulas and why they're important to diversifying the workforce. This is a map that looks at where doula coverage is being paid for by Medicaid. This was pulled in the beginning of August, so it may be different now. There is an incredible program called the National Health Law Program that looks at the coverage for Medicaid and can offer all kinds of amazing information about their programs going on throughout the U.S., as well as fees and coverage for reimbursement. In addition, we know that midwives are an underutilized healthcare expert in the United States. We would need 93,000 midwives to care for every baby that was born. Currently, we have 14,000. This is another piece of information that we know is helping to improve birth outcomes, and that when they're parts of the healthcare provider team, we have really wonderful outcomes as well with midwives. You can see that the midwifery population is diversifying, but is somewhat different than what we really want to see to match the population. There are many challenges and barriers when we think about using midwives, and you can look at those here. This is an opportunity for us to think about how we in Arizona can advance the midwife certifications and use, and I'll share a little bit about the way North Carolina is doing that. Another goal is increasing access to and coverage of comprehensive, high-quality maternal health services. This is where we see an increased attention to community health workers from the national blueprint. This is also something that, congratulations, that Arizona has done an amazing job advancing. As of April, you have passed legislation to begin looking at the licensing and the certifications of the community health workers in their importance in a public health workforce. This shows you from July of 22 or May of 22, you'll see how many community health workers we have currently. This information is available online. You can see here that we have a pretty diverse population of community health workers. And you can see here that we have a variety of community health workers with lots of different education. Community health workers can be such an integral part of the work that is being done at a community level and at a state level. As we move into some of the advances that Arizona has done as far as getting it into legislation, we can really think about how they can help to support our doulas, our midwives, and our other populations of healthcare providers working to support maternal and child health. A couple of other goals are around the social determinants of health. These goals and actions focus on interpersonal violence, addressing the social determinants of health, workplace benefits, and a couple of other ones. This information will be available on our website moving forward. I want to take a couple minutes and just share with you a couple of programs in North Carolina that we are working on at the state level and with different funding streams. So the Maternal Health Innovation Funding is the same that Arizona has. We are focusing on doulas and community health worker initiatives. The doulas have been added to our home visiting program, and they will actually be focusing on trying to work with women who are pregnant in 2 of our northeastern counties of the state, and they are being contracted with one of our federal tribes that is recognized, and our federally qualified community health centers. Baby Love Plus is our North Carolina home visiting program, one of them. We also are working with AHEC, which is our Area Health Education Centers. We are working to educate high school students and four-year college university students, as well as community college students, about what maternal and child health is and how they could get involved. We're doing this in a number of different ways, and in the fall there will be a high school program where we bring students together to really think about maternal and child health as a future career. The session law, this is the one about the certified nurse midwives. We are hoping that we will be able to pass this session law so that we will not necessarily need an attending MD if the certified nurse midwives has the certain number of years and hours of experience. And this could really help with our rural public health departments. We have 83 public health departments and 100 counties. And so this could really help with having enough OB coverage in those counties that are certainly understaffed. We are in the process of passing Medicaid and putting it into process, so we're very excited. And we are looking at some of our PHPs doing doula reimbursements. Another really amazing program that has just started within the last year is called Believe. They work to improve systemic and structural causes of maternal infant mortality by building genuine trust between healthcare teams and patients. So this is a communications project with some of our HBCUs. It is part of a larger project, and it has been around for just about a year. We anticipate and hope that doulas and midwives will also be part of what we consider the healthcare team to increase bidirectional, respectful communication. Another one that's been around for about 3 years now is our LEAD program, which is a Lived Experience Accessible Doula project. This is in its second round of funding from the Duke Endowment. The principal investigators seen on the screen provide an 8-week doula training program through DONA. They call it DONA Plus because they also give them information on communication, respectful care. They work with them to help them understand how to set up their own doula services. And we have had most of the doulas that have been going through these 5 cohorts, about 15 to 20 over the last 3 years, support more than 300 Black birthing people in the state. And you can see the birth outcomes have been very, very well and very, very positive. One of our other projects that we have in North Carolina is called A Cure for Moms, and it is a randomized control trial with PCORI and Duke Endowment funding. They are partnering again with our area health education centers and 2 different CBOs, community-based organizations. And they again are aiming to decrease complications for all patients. And they're doing a randomized control trial with 4 different groups. This is new funding. And I think the point of sharing these different opportunities in North Carolina is to really show that when we think about collaborative approaches to funding, we can really kind of get outside of some of the standardized funding that we get from the federal government and the state, and think about how we might be able to get funding for other programs and collaborate across the state and with other academic partners as well. A company doula is out of Massachusetts, and I'll leave you with the slide here just to show you that they are doing some really good work in Massachusetts with their doula program. They have reports online. They have a really wonderful report about how they switched to virtual care during COVID-19. They received some funding from MTAP, which was a healthcare grant for 1 year. And so they've got some really wonderful reports, and they also have some information about how they recruit partners, meaning hospitals and other organizations, to support the financial needs so that women can have doula services.
Leslie, thank you so much for your presentation. It was really quite wonderful to hear. I know that you are a little short on time. We do have one question that came in. The question is from Isabel Fangman, and her question reads, when we talk about midwives, are we talking about CPMs, home births / birth centers, or CNMs, birth centers and / hospitals, or both?
So that's a great question. And in the data that I was presenting, they have a tendency not to separate out the data when you look at it holistically. So when we use the word midwives, we are using it holistically. So it's going to encompass all of those. I will tell you that the Maternal Health Learning and Innovation Center has an evidence to action brief that we are writing on midwives that does identify how the differences between a certified midwife or a home birth midwife and how they can support the MCH workforce and providing positive outcomes for MCH. So that will be on our website in the next couple of months.
Thank you for that feedback. The other comment that came in is Pearl A mentioned that she thought you provided a great description of equity and equality. So kudos to you for that piece.
Oh, thank you.
Another item that came in states the midwife program that doesn't require OB backup. Has that passed, and what state? That's from Dan.
It's in North Carolina. Yeah. Dan, that's in North Carolina. It is under, what do they call it? It's under review, I guess is the best way to say it. So they are looking at it right now. It has not passed, but you can go to the slides and look up that session number. And I can pull it for you very quickly. The session number is Session Law 2023-14 if you want to read more about it.
Thank you. That was his follow-up question. If you had the bill number to be able to review it. I think that that's really remarkable information for other states to look at what's going on in your state. Another question that came in just momentarily from Jenna Sanders. Whoop, my screen is moving way too fast here. Are we talking about state licensing requirements or hospital bylaws? The state of Arizona does not require OB backup for independent licensed advanced practice nurse practitioners and CNMs, certified nurse midwives.
So the law currently is going to be a state licensing requirement. Supporting our public health departments, as far as I understand. I don't actually have information on our state hospital bylaws. I would be happy to try to look that up for you and get that back to you.
Thank you.
And one of the challenges with the midwives is that every state is so different that there's a lack of standardization. So that's one thing to think about. How do we move that forward nationally and advocate for that?
That's an interesting point. Do you think that the packs that some of the states have come up with for nurses, would that be making an impact in standardizing some of those expectations?
I think so. With the little bit of information that I've read about midwifery and looking at the national organization, one of the opportunities we have is to think about how we can advocate together and move this work forward, because it's very challenging if somebody can practice in a state without supervision but then they go to another state and they can't
Mhm.
practice, right? And if we think about the changing demographics of our populations and people moving, if they move from one state to another and they have midwifery services in one state but not another, it can be also challenging for that. So I think the more that we can be standardized, the better. And again, that's probably many, many years down the road, but it's what we need to advocate for.
Yeah, and Jenna Sanders replied and said, agree, thanks. We need CN certified nurse midwife licensing to be federal rather than state by state.
Agree, 110%.
Okay, that appears to be the questions that came in for your presentation. Leslie, again, it's a pleasure to meet you virtually, and thank you for all of the work that you do in Arizona and throughout the country.
Well, thank you, and I appreciate this opportunity and just want to say a big shout out to the Arizona MHI team for all they do. You all are doing amazing work in Arizona, so thank you for this opportunity.